This evening, we are still continuing with our health assessment, and today I want us to look at the respiratory assessment. So, we are going to look at the respiratory system, how we are going to assess basically our patients in relation to the respiratory system. So, we have to get the subjective assessment and also the objective assessment, whereby we started in our first topic when we just introduced the health assessment that we have to collect data in two ways. We have the subjective data, whereby we do the subjective assessment. Then also we have the objective assessment, where we collect the objective data. So basically, when you look at the objective data, we have to collect the data using the interview questions, and the objective data that we collect is basically how the patient will respond to us. And this one is us ourselves who are going to collect this data based on the questions that we are going to ask from our patients, and depending on how they have presented to us. And then in consideration of this, we have to look at the patient's age. How old is the patient, the gender, because in most cases, some of these conditions are related to the age and the gender. Then also the family history is very important, because the family history can give us a clue whether there is a kind of hereditary kind of infections or conditions or diseases that some of these patients can present to us. Then also the race of the patient, the culture, and then the environmental factors. Those can be most of the questions that we can ask, and not forgetting the current health practices of these patients. So the interview questions for subjective assessment of the respiratory system, you really have to diagnose this in relation to the different ways the patient comes to you. So, have you been diagnosed with respiratory conditions? That is one of the questions that you can ask the patient, whether he has ever had this kind of conditions like asthma, COPD, pneumonia, and other allergies. So, someone may wonder and say, what is the COPD? COPD is basically the chronic obstructive pulmonary diseases. These are some of the conditions that obstruct the airway. So there are a number of group of different conditions that can block the airway of a patient, depending on what kind of lifestyle the patient has been, and it is most commonly with patients who have been smoking. So some of these problems can also be like chronic bronchitis, the inflammation of the bronchi. It can also lead to COPD. Then emphysema can also be one of them that can lead to chronic obstructive pulmonary disease. So when a patient comes to you, you can first inquire from them whether they have had this kind of conditions, and asthma is one of the hereditary conditions that some of our patients can have. And allergies can also be one of them. Some of them might be allergic to certain things, and when they come to you, when you ask them, they may be able to tell you that I'm allergic to maybe this kind of either smell of either oils or even foods that can lead to maybe increased secretion of a lot of mucus around the airway and can cause an obstruction, and this can affect their respiratory system. So you have to ask them use of oxygen or peak flow meter. You also need to know about that. Then they use if they use home respiratory equipments like the CP. This is the CPAP. Most of us may have seen this, and we use them basically. Most cases we see them in the neonatal unit, and this one can help in making the lungs keep expanded, and the patient can have continuous breathing in case of any issues that affect the respiratory system. So when you ask them this, they can be able to tell you whether they have been having this, and in case they mention that kind of thing, then you know this patient has been having this condition for a long time, or the patient is even taking kind of treatment for a long time, like the nebulizer. Nebulizer can be done especially for patients with asthma. So when you ask them such questions, they can be able to tell you, and also you need to know the current medications for respiratory concerns. So if they tell you there are some drugs that they are taking, you can be able to identify, and you can be able to understand whether it is the course of these drugs that might have given this patient a difficulty in breathing if he has reacted to them. And then also experience breathlessness. Some of them may tell you, sometimes I feel I cannot breathe. I feel difficult in breathing and I feel I cannot take in air, I cannot release out. And that one is called dyspnea, where there is difficulty in breathing. And these patients can come to you and they present to you with such kind of complaints, or they might have experienced before they come to you. So you need to find out from them. And then also shortness of breath, rating from 0 to 10. Below 12, this is not good. Below 12 breath per minute is not good for a patient or for a person. So when they tell you this kind of rates, then you just know this patient has a very big problem with his respiratory system. And then triggers for shortness of breath. You also need to know what could have triggered this patient to have that kind of shortness of breath. Sometimes it can be due to certain conditions or certain lifestyles or allergies and so forth. So you need to know the triggering factors that could have contributed to shortness of breath among your patients. Then also the onset and duration of shortness of breath, you should also know. When did it start? How long has it taken? And then you can be able to intervene accordingly. Then also the associated chest pain or discomfort. When the patient is having either difficulty in breathing or the patient is having some kind of shortness of breath, and when you ask them, they may tell you, I feel there is also chest pain, and maybe it is radiating to a certain side, and you can be able to associate it with certain maybe kind of conditions. And also the discomfort, the patient may tell you, I don't feel comfortable when I'm lying flat on my bed. I don't feel comfortable when I lie on the side. So those can be the associated kind of chest pains in relation to maybe positions when the patient is lying or when the patient is sitting upright or lying on the side. Dependencies, the patient may tell you, when I try to dig, I feel I don't have enough breath, I have difficulty in breathing, I have a loss of strength, and so on. So the effects on daily activities also can be one of them things that the patient may present and tell you. So when they come, ask them all these questions. And when you ask them all these questions, you should be having the rationale and you should be having the reason as to why you're asking them, so that you can be able to articulate the respective answers to your questions, and they can be able to come up with the right problem for your patient. Then cough, presence, is there a cough, and what is the color of the cough? And the patient may tell you, when I cough, I release a sputum, and maybe it is bloody or it is just like mucoid and so forth. So all that you can be able to interpret, and you can be able to come up with the right diagnosis and make the right judgment and treatment for your patient. And also there can be some other associated symptoms with cough. When the patient is telling you, when I cough, either I end up vomiting because maybe the patient is straining so much. So there you can be able to understand what this patient is going through. So there are so many things that the patient may tell you that could be associated with the cough that is going on with him, and there you can be able to relate it to some other factors. Then smoking, you should also ask your patient whether he's smoking, the history of smoking and the details. How long have you taken smoking? What kind of or type of cigarettes do you take? And so on. Because nicotine is also dangerous to our blood vessels and can cause a lot of havoc to the respiratory systems. So when a patient tells you that he is a smoker or he has been smoking, we should not take this for granted. We should be able to dig out all the information related to smoking so that we can be able to intervene and support our patients. So we also need to know the lifespan considerations, and I want us to start with the pediatric. These are the young children. Many times parents bring us their children and they say this child has taken this kind of period with cough. And we know there are a number of conditions that our children go through, number of diseases, immunizable diseases that also can cause cough, whooping cough, and so on. So when they bring these children, we need to also find out in relation to the questions that we are going to ask them. So, having mentioned about immunization, we also need to find out whether our children have been immunized fully. So, you have to ask for the immunization status of these children from the parents, and then you can be able to gauge what kind of problem this patient or this child is going through on what has caused the cough. Then, cold symptoms in children can also be one of the triggering factors affecting the respiratory system. They can bring for a child, you see there is running nose, the child is sneezing, the child has some kind of slight cough. It may not be all that, but you really see there is some cough, there is running nose, and this can cause even pneumonia for these children. This can affect the respiratory system. This can trigger the allergies, even asthma. So when you look at them coming and they have these cold symptoms, don't take them lightly. They can be the triggering factors to the respiratory conditions that they have presented with. The changes in appetite or wet diapers, you should also find out whether these children are eating normally or they have changed their normal ways of eating and so forth, so that you can be able to address them. Then respiratory hospitalization history. Has the child been hospitalized due to respiratory tract infections? And if so, what was it and how was it managed? How long did it take? And what treatment was it given? How did the child respond? All those questions are very important for you to start on the management of these children. Then history of frequent ear infections. This one is also very key for you to find out whether these children have gotten any respiratory, ear infections, because you know very well there are a number of connections between the ear and the respiratory system. So those connections can also cause infection to the respiratory tract and therefore causing a lot of havoc into the respiratory system. So this has to be noted and this has to be clear so that you can be able to connect and articulate things as a health worker. For the case of the older adults, when they come to you, there are things that you're also supposed to ask them. You're also supposed to find out whether there are any changes in their breathing. And they may tell you, I'm feeling difficult in breathing. Sometimes I feel shortness of breath. Or when I do this, I feel a lot of changes that they may tell you. So there you can also be able to interpret and come up with the right diagnosis. And I've already mentioned about shortness of breath with new activities. The person may tell you, when I try to do this, I feel I lose my breath. And there are a number of activities that they may present to you, and they tell you, I feel I cannot do it anymore because whenever I try to do it, I feel I cannot breathe, and so forth. Maybe even doing exercises, they cannot run, they cannot do much work, they cannot lift things, they cannot either climb somewhere which is a bit hilly. So those are the kind of activities that sometimes these adults may tell you, and then you can be able to come up with a certain kind of clue on what your patient could be going on in his life. Then also the energy level changes. Also you have to find out. They can tell you, I don't have enough strength to do this and this kind of activity. I feel I'm getting weak and so forth. So in case they come to you in that way, then you can be able to gauge and get more information about the explanations and the complaints that they have given and presented to you. So looking at the objective assessment, and this objective assessment, as earlier on mentioned, as we started our lesson, I said in objective assessment, this is basically the data that you're going to collect as you, the health worker. And in relation to the objective assessment, the health worker has to take the initiative by him or herself to look for the information. So when you're looking for the information from your patient, there are very many things that you're supposed to actually carry on or do as a health worker. You are most welcome. I see someone has logged in. Hello.
Yes, good evening.
Good evening. How are you?
I'm fine, thank you. How are you?
I'm okay. So may I know the person I'm speaking to?
This is Bansuk Winnie.
Yay, you're most welcome. I think this is the first time that I've heard you. Am I
Yeah,
right?
I think yes, it's your first time, and health assessment. I think it's part of me.
All
That's
right.
why I've joined.
So all right. So you're most welcome. We're trying to go through the objective data and we had finished the subjective data. And I remember when we just started this health assessment, we had tried to explain and we said the subjective data is basically the data that the patient gives us. So when the patient is expressing himself, telling you what is going on within him, that is basically the subjective data. Then now when you look at the objective data, this is the data that we get as the health workers, and these ones you can use very many signs that you look at from the patient and you can be able to say that this patient has this problem and so forth. Then also when you look at the vital observations, when you carry out the vital observations, looking at the respiratory rates of this patient, the pulse, the blood pressure, that one is also under objective data or objective assessment because it's you, the health worker, who is collecting this information. It's not the patient. And it's you to interpret it, it's not the patient. So this lies also on the objective assessment or objective data. So when you look at the respiratory rates, the normal one is supposed to be 12, between 12 to 20, that is the range. So this can be taken when the patient is at rest. Don't take it when the patient is either running or doing a certain activity which may increase the number of rates. So when you take this, it should be between 12 to 20 breaths per minute. Then the pulse oximeter, pulse oximetry can also be done, and that is looking at the SpO2s of the patient, that is oxygen saturations, and the normal range is around 94 to 98%. Some patients can even reach to 100, but they always say reaching to 100 is not good for a normal person, and also below 95 is not good. But according to the ranges, we look at 94 to 98%. So when your patient comes and he's below 94, that means this patient needs an intervention and the patient may end up being put on oxygen therapy. And I believe that's what we have been doing. Am I right? Bonsuk, am I
Yeah,
right? Is that been doing?
yes, you're right. I'm fine.
Okay. So when you look at bradypnea, that one is basically when the breath is below 12. So when you carry out your patient's respiratory rates and the patient's breath is below 12, then you know that these patient's rates are not okay. And that's when even you end up putting the patient on oxygen. Besides looking at the pulse oximeter, that you have decided to look at the SpO2s. So when the SpO2 is below 94 and then also you've counted the breath and they are below 12, then your patient needs an intervention immediately. And then also tachypnea, that one is the increased breath. Having mentioned the ranges 12 between 12 to 20. So when the patient's breath is above 20, then that one is tachypnea, meaning the patient is trying to breathe very fast, trying to grasp the oxygen, and in this way you can also support by giving oxygen therapy. So there are so many things that you have to look around in your patient in relation to objective data. And when you're able to identify this very fast, then you can be able to intervene and save the life of your patient. So for the case of objective data in relation to inspection, you have to also assess the level of consciousness of your patient, and you can be able to gauge whether your patient is conscious, unconscious, semi-conscious, and you'll be able to tell the levels of consciousness of your patient just through inspection. Then also the respiratory rates, the pattern, you can look at the rates, you can look at the patterns, whether they are regular or irregular. You can look at the effort, and the effort is basically whether your patient is laboring in breathing or the patient is having a normal breathing. So you can look at that, how much is the patient struggling to breathe, and then also use of the accessory muscles for breathing. So as the patient is breathing, you can just observe or inspect, and you can be able to see what is happening in relation to respiration. Then the skin color can also help to tell us so many things in relation to the respiratory system. The chest configurations can also tell us how is the chest of the patient when he's breathing, and then the symmetry of the expansion. When the patient is taking in the oxygen, how much is his chest able to expand? So when you're observing or inspecting your patient, you should not just look at the patient, but you should be able to articulate so many things that can help you come up with the right assessment. And also the data that you collect should be the data that can help you come up with the right diagnosis. And when you come up with the right diagnosis, you shall be able to manage your patient very well. But if you misfire in the data collection, you'll also misfire in the diagnosis, then you'll misfire in the management, and then you'll not achieve what you expected as a health worker to save the life of your patient. So the skin color is also very key. If the patient is not having enough oxygen, it can tell you, the color itself can tell you that this patient is sick. And when the patient is sick, this patient will need some oxygen. So many things can be done in relation to uh, respiratory system assessment. When you look at auscultation, when you're auscultating this patient in relation to respiratory system assessment, you have to use the stethoscope. And I remember when we started our lesson in relation to this, basically this module or this subject, we talked about the introductory part and we mentioned the different techniques on how we are supposed to assess our patients. As someone has logged in, I want to say you're most welcome. Hello,
Hello,
you're most welcome. I'm speaking to.
Dennis.
Okay, you're welcome. So, you found us in this other slide talking about auscultation, and basically, this subject is about health assessment, and today we are looking at respiratory system assessment. So, when you're looking at your patient that he has come of respiratory conditions or a problem in his respiratory system, how are you going to assess this patient? What are you going to do that can help you in the management of this patient? So as you joined in, we're concluding on the inspection, and I remember I mentioned that when you're inspecting the patient, you have to look at the levels of consciousness of your patient. You have to look at the respiratory rates, the patterns of the respiratory rates, at the effort of the patient when he's breathing, is he laboring, and then also the use of the accessory muscles. Sometimes when they have difficulty in breathing, they end up using the accessory muscles to help them getting enough oxygen. And then the skin color, also, when the patients are cyanosed, that means they are lacking enough oxygen. Then the chest configuration is also very key. There are intercostal recessions that can tell you that this patient is struggling. Is the chest expanding in a symmetrical way, or it is having an asymmetrical way, meaning that the sides of the chest, when you look at the chest, you realize one side is either expanding while one side is not, but they are supposed to be uniform. So they have to be symmetrical in expansion. They have to move at the same pace. So those are the things you have to look at. And in this slide, we also talked about objective assessment. And I remember during the introduction of the health assessment, we mentioned that objective data is collected by you, the health worker. So even the vital signs, it is you, the health worker, who collects them because you're the one who is able to interpret. It's you who is able to assess the patient in relation to these vital observations. So that is objective assessment, and it is an objective data that you're collecting. That's what we have been trying to explain in this slide, and then you logged in. So when you go to auscultation after inspection, you're supposed to use a stethoscope. And in our introduction, I remember we introduced, there was a slide that was having a diagram of a stethoscope, and we had labeled all the different parts of the stethoscope. So you use the stethoscope, and it is the diaphragm. So you have to listen to the air movement during the inspiration and expiration. So when you're listening, you should be able to have the knowledge and the idea on how the normal air is supposed to get into the lungs and how is the abnormal one, so that you can be able to tell whether the patient is having whether the signs are indicative of any abnormality or the patient is not having any problem. So you should also be knowing the different signs that are abnormal and also the normal sound that the patient should be having when he's breathing during this time of auscultation. So you should use the correct stethoscope, and place it, and placement of it is very crucial. So sometimes people do not know which side to place for listening to the chest and which side to place for listening to the bowel sounds. So when you use the other side, which is not actually for that side, then you may not be able to get the normal sounds. So correct stethoscope placement is also very crucial for you to get the normal sounds and for you to be able to differentiate whether the sounds you're listening are abnormal or they are normal. Then expected breath sounds, you should also be able to know that the bronchial, you should be able to listen to them and hear what kind of sound. Then the bronchovascular, you should also be able to understand. So when you're able to articulate all things in relation to the sounds, then you can be able to tell this patient is having an abnormal sound, and what should I do? Or what kind of abnormal sound, what kind of condition could this patient be having in relation to that abnormal sound? Then also check for the signs of respiratory difficulty. And we said very well that sometimes our patients can have labored breathing. So you have to look at that. Our patients can have intercostal recessions, or they have asymmetric kind of expansion of their chest during the time of breathing. So all that we have to analyze when we are doing the auscultation. So if there is any sign of difficulty in breathing, what could be the problem? What could be the cause? And they can be able to address their issues. Any questions so far? Is there any question, or we continue?
Yeah, we can continue. Thing is clear.
All right, thank you. So in this slide, we have a heading that is telling us adventitious lung sounds, and these are basically abnormal sounds. So these sounds are heard alongside normal breath sounds. So you should be able to differentiate. So when you're not able to know that when a patient is breathing and this kind of sound is the abnormal one, then you may not be able to differentiate the normal one. So you should be able to tell that this is an abnormal sound and this is the normal sound. So when you listen, you can be able to tell this is an adventitious kind of lung sound, which is not a normal one. So it is always heard alongside the normal breath sounds, often indicating the airway issues or diseases. So this include the coarse kind of crackles, that is the rhonchi. So when you're trying to listen using the stethoscope, you may hear some crackles and you may understand this is not normal. So there can be low pitched, loud, continuous sounds on expiration, which is not a normal thing. So when the patient is breathing and you put your stethoscope and you're hearing that kind of crackles, it is either loud or sometimes it is low pitched but is a crackle, and it may continue sounding when the patient is having expiration. That is when the patient is taking in the air. So then you can be able to suggest maybe this is a different condition. This is not a normal thing that a human being should be having when he's breathing in. Then also the sign of turbulent airflow through the secretions in the large airway, that can also give you that kind of coarse crackles. So when you hear this, then you can be able to gauge that this is not normal and this patient may need what? An intervention. So as you're listening to these adventitious lung sounds, you should be able to differentiate this rhoci, and that is the crackles. So they can be making some funny sound when you're listening as the patient is breathing in and breathing out. So when you listen to that and you think it is not normal, then you should also go ahead to investigate. You can do an X-ray to find out what is happening in your patient's lungs, and there you can be able to intervene according to the findings of your X-rays. The others were called crackles, but these ones are basically the fine crackles, and those fine crackles, they are not the ones that are coarse. The ones that are coarse, sometimes when you step on a leaf, there are some places you can go and you find that the tree has dried and the leaves are fallen at the floor, just around the floor. If you step, the sound of those dry leaves as you step on them is related to the coarse crackles. That is an example I can give. So when you listen to your patient and it is like someone has stepped on the dry grass, then you just know those are the coarse crackles and it is not a normal sound. Then the fine crackles, these ones are popping or crackling sounds on inspiration. And remember, for the case of the coarse crackles, that is during expiration. But for the case of the fine crackles, it's during inspiration. So that is the difference. So when you listen on some crackles, when the patient is actually having an expiration, then you know those are the coarse crackles. And then when the patient is breathing in, and you listen to them, they are fine, they are not very rough like the other one, then you know this is fine crackles. So it is associated with conditions causing fluid accumulation in the alveoli and the interstitial spaces. So when the patient is having this kind of conditions, when there is fluid that has accumulated in the alveoli of the patient, then the patient may actually have this kind of crackles. So when you listen to this, when the patient is having an inspiration, then you should start suspecting that this patient should be having fluids in the alveoli or around the interstitial spaces of his lungs. And you can do a scan, you can do an X-ray, and it can actually show you that there is some fluid accumulating somewhere within the chest around the lungs. And for it is soft, high pitched, and brief. Whereas when you look at the coarse crackles, for it is low, loud, continuous sound on expiration. So for it continues, while this one for it is a short one, and also it is a high pitched, while this way it is low pitched. So those are the differences between the two kinds of adventitious lung sounds in relation to the crackles. Then the wheezes, I believe most of us have got clients with asthma. Can someone tell us an experience? Hello, Unzima. Uzmai, let me not pronounce your name wrongly.
Yeah,
Yes.
yeah, that's correct. Yeah. So yeah, thank you. I think the wheezes, yes, yeah, these are normally common with asthmatic patients, and it's exactly, of course, like that kind of like whistling sound. So when you auscultate like the chest, to even sometimes don't auscultate to be able to even hear this without even the scope.
Mm-hmm.
So normally, yeah, exactly, you can hear. So it can be like so. Sometimes the patient will, of course, run sort of course, the oxygen. So definitely, you will know even without auscultating. So for these diseases, it's really prominent, and also it is not only sometimes in asthma alone. Sometimes even bronchitis. Sometimes you can hear also some of those wheezes. They are not like asthmatic one. I think
Oh,
that's what I really know.
all
Yeah.
right. Thank you so much. All right, thank you so much. Actually, what you've mentioned is very true. It looks like somebody is whistling. So it is kind of a whistling type of noise during expiration. So it is mostly during the expiration, and sometimes can also be in inspiration, but majorly it is during expiration. So it results from the narrowed airways due to bronchoconstriction and mucosal edema. These patients end up secreting a lot of mucus along the bronchi. So it causes narrowing of the broncho lumen, whereby the oxygen is having difficulty to pass in, and also during the time of expiration, the carbon dioxide is also having a difficulty to be expirated. So that's why this sound comes about due to that narrowing of the bronchi due to increased secretion of the mucus substance along the bronchi, and it causes edema. So there are so many things that happen. The inflammatory process takes also its part along the bronchi, and that's where we find increased secretion of the mucus substance. So as you've mentioned, it's basically common in patients with asthma, but sometimes even patients with foreign bodies can have this kind of wheezing. So you have to listen for it. And when you listen for it and you get that the patient has this wheezing, then you can suspect it to be asthma and maybe also a foreign body. And sometimes for the case of foreign bodies, if it is not a big foreign body, you may see that the wheezing sound is very low. If you're not keen enough, you may not even hear it. But those patients sometimes can present with that kind of wheezing, but very low. And then Strider, is there someone who can tell us about Strider? Yes. Bon. Can you complete for me the name? Yes.
Bansuk.
Bon Soak, yes. Thank you very much. I wanted you to tell us an experience with the Strider. Have you ever gotten a patient with Strider? Yes. All right. For the case of Strider, you find it's hard on inspiration, and this one happens more on children and also when someone has a foreign body. So it is associated with mechanical kind of obstruction at the trachea, especially at the upper airway. So you can listen for it and you can hear it. So when you hear Strider, there is a sound. Hunzima, Hunzmai, can you tell us? The other time we tried to bring out the sound of wheezing. Can you also try to bring out the sound of the Strider? Have you ever encountered these patients?
Yes, but now I've actually forgotten that. And let me first get, and then I will
Okay.
do it. I forgot now.
For the
Yeah,
sense of the
sorry.
Strider, let me see if I can. It is like just like that. Have you heard?
Exactly, that is it.
So
Yeah.
our patients with Strider, that's how they present. So you need to listen to it and you realize this patient has a problem. There could be an obstruction. And when you look at this statement associated with mechanical obstruction, meaning mechanical is like there should be something like either a foreign body that has blocked the trachea or any part of the upper airway. So these patients come and they shall be presenting with this kind of sound. So you start suspecting basically an obstruction. And then the pleural rub, this one is hard also on inspiration, just like the Strider, or also in expiration. So for it can happen in both. So the sounds are just like rubbing the leather. So when you get leather in your two hands, then you rub it together. The sound that you hear from that rubbing of the two, the leather is just like the pro sound. So the pro cavities rub each other just because there is maybe an inflammation around the lungs, and to always give you that kind of sound, like something is rubbing along like a rubber, and you may be able to know that there is something happening at the lung pleura or the pleural cavities of the lungs. So it indicates inflammation of the lung pleura causing friction. So when there is inflammation, you realize the lungs can get in touch with each other. So when the patient is breathing, they'll be rubbing onto each other, and that is what will be called pleural rub. So it is also a sound which shows you that there is an abnormality happening, or there is a problem within your patient's respiratory system, basically looking at the lung pleura. So I want us to look at the lifespan considerations, especially in children and also in the older adults. So for the case of the children, the respiratory rate of the infants is supposed to be the ones of less than 12 months. 12 months is less than a year. They're supposed to be between 30 to 60 breaths per minute. So when you see the patient has come, who is an infant, and the breath below 30 or they above 60, then there you should be suspecting an abnormality in the patient's respiratory system. Then irregularity, it is more of the newborn. So irregular newborn breathing in the first weeks. You count the respirations for a full minute. So you need not to count. People always, when they tell them either to count for 1 minute, they decide to count for 15 seconds and then they multiply by 4. Or they count for 30 seconds, then they multiply by 2 to get 1 minute. But I always encourage most of my students that do not always do that. If they say 1 minute, basically give time to your patient and count for 1 minute. And many times you have realized that when you count for 1 minute, you can find that there may be an irregularity in the middle before you complete the 1 minute. You may start very well, the breath are regular, but when you reach in the middle, before you end the 1 minute, you realize there is an abnormality. Either there's irregularity or even there's apnea and so forth. So you should not always count for seconds, then you multiply, but endure to count your patient's breath or pulse for strictly 1 minute as expected as a standard. So up to 3 months, infants are obligate. There is always some kind of breathers whereby these patients sometimes when they come to you, as the mothers bring them around this age, there can be nasoflaring, there can be using their mouth for breathing instead of using the nose, and sometimes for their case it may be normal. So there are things that we need to understand, that if a patient is at this age, what do we expect of them? If a patient is older, sometimes their respiratory rates or their breath or the way the different parts or the organs that support those activities, there are changes that can occur in them, and for that age it may be normal. So there are things that we need to look at. And also yesterday, as we had a lesson, I remember we came up with some of the abnormalities that people may think they are abnormal, but when they are normal in all the age. So we have to also put those ones in consideration so that we don't diagnose our patients and yet that is normal to them. So for the older adults, the cartilage and the muscle support weakens. This is what I've even been trying to say. So there are certain things, as someone is growing old, the structures in different organs get also deformed, or they deviate from the ones that when somebody was still an adult or young. So the cartilage within the respiratory system, the tract, and the muscles that support become weak. So the way they breathe may not be the way that you, a strong adult or the middle-aged person, is breathing. So this one can lead to decreased chest expansion. So because of this cartilage and the muscle support becoming weak, even the way they breathe, their chest does not expand so much as that one of someone who is still having those strong muscles and cartilage. Then also there's weakened respiratory muscles, which may result in shallow breathing. So as they breathe, they may not breathe so deep as you, the elder person, is to breathe. So those are some of the things that I think we should be putting into consideration, that when we get these patients, let's not categorize them having maybe certain conditions, and yet it's basically due to their age that has contributed to the way they are breathing, or the way they are actually trying to carry out their normal activities and so forth. So we need to know and to understand when somebody is young, what happens, in the middle age, what happens, and when they are old, what happens. So here is actually trying to tell us, when someone grows old, all the systems in their bodies actually they degenerate. So you cannot compare the activities in their systems to be the same way as those ones who are middle aged, or those ones who are tissue data, which is basically related to percussion. So when you're percussing, you should also be able to know what sound comes during the time of percussion. What is the normal sound as you're percussing the chest, and what is the abnormal sound when you're percussing the chest. So you should always be able to know, so that you can be able to articulate things, that this sound is related to this condition. So when I percuss and this sound is what I hear, then this patient should be having this condition. Or when I percuss and this is the sound I get, this is a normal chest sound. So percussion, we also have to have the skills and the knowledge on what happens exactly when we are carrying out percussion on the chest. So this helps us to also gather information, and is one of the techniques during our health assessment. So dull sounds indicate high density areas, and that is maybe when a patient has pneumonia, atelectasis, and also it can be due to white, clear, low pitched, and then hollow sounds are normal ones. So when the patient comes to you and you percuss and they are dull sounds, when they are dull sounds, then it means this patient has a problem with his chest or the lungs. So there can be either lung consolidation, where there has been either infection and it has formed scars along the chest of your patient, especially pneumonia can cause that. So when a patient presents and you do percussion and there is a dull sound, just suspect the patient is having a problem, because the dull sound is not supposed to be on the chest. Then atelectasis is also one of them. It can be so when the patient comes and the patient is showing this kind of sound, then you should be able to gauge some abnormalities and relate them to certain conditions. Atelectasis is basically, what is atelectasis? Let me not say it. Uzima. Yes? Uzmai, what is atelectasis? Hello, have you left me alone in the session?
Yes, I'm
I was
here.
Yes, I was asking, when you
Mm,
park and you get a dull sound, and they
yes.
say it can be either pneumonia or atelectasis. So I wanted you just to tell us what atelectasis is. What does it mean?
Yeah, athletosis means, I think, it is the collapse of the lung or part of the lung.
All right. Yes. So
Yes.
when you percuss, thank you. So when you percuss your patient and you realize that there is that dull sound, then you can start suspecting either your patient is having pneumonia or atelectasis, either the lungs have collapsed. It can be both lungs, or it can be just one lung that could have what collapsed. So you should take an initiative to find out what is the cause of that dull sound, so that you can intervene. Then while the clear sound, low pitch, hollow sounds on are what are the normal ones. So if you percuss and you find the sounds are very clear, showing you there is nothing obstructing the airway, and they are low pitched, they are not very loud, and it is a hollow kind of sound, it shows like the space is, there is a space, that is the hollow sound. So meaning there is nothing obstructing. So that is the normal one. But when you see that there is a dull sound, then you suspect pneumonia and then atelectasis. And also pneumonia causes lung consolidation, and when the lungs are consolidated, when you do percussion, it gives you that dull kind of sound. So basically, I think that is the end of our session for this evening. And I want to appreciate everyone who was able to log in and interact with me. I always love interaction when teaching, not only me to talk. So I appreciate for your contributions, and I pray that next time we shall always be together. Thank you. Yes.
Yes, thank you so much. What about plural infusion? Like if you do percussion, what will be the sound like? Is it dull? Because
The
there is diminished tree when there is a plural infusion, like in a patient. What
it
will
can
be the
also
sound like?
it can also be dull.
Okay.
It can also be
Yeah.
dull because the fluid has actually accumulated and it has taken up the space in the lungs. So it is more of the consolidation around those lungs. So it will also be dull. So any dull sound, you should always take note of it in relation to percussion. So that's why I'm like, when you do percussion and you see there is that dull sound, don't just stop there and say this is pneumonia, this is atelectasis, but also go ahead and do a chest X-ray, and that one can help you actually to clarify what is happening in your patient. And then besides that, I remember we talked about the prorab. So when you're also doing auscultation, you can also hear the prorab. So that one can also be an indicative sign for you to know that there is fluid in the procavity of my patient's lungs. So when you go ahead to pass and you see that there is that sound, then there you can just know, and then you can confirm with the X-ray.
Okay. Thank you so much. Another one. I just also wanted to ask before about the lifespan consideration, especially the new net thing. I think it
Mm,
is very good. I appreciate you emphasizing that because I also realize that there is a lot of discrepancies when it comes to vital sign taking, especially in the new net, because of the irregular breathing in the new net. Because for sure, I had this experience because I work with a lot with children, and find that when the nurses are taking vital sign, as you say, like the 15 second, the 30
mm,
seconds, people like to do that because they say, okay, I want to just do it faster, like, to hurry.
mm,
But I
mm,
realize that most of the vital sign will not be correct because of that. I think it's
yes.
really good for me to really take it like 1 minute for sure. I fully agree with you. Thank you so much for
Mm,
that. Yeah.
you're welcome. Thank you so much. I think we have come to the end of our session for this evening. Unless there is any
Thank
other.
you. Bye.
Thank
Thank
you.
you.
All right, teacher, I didn't hear you today.
Yes, I was around. I was listening.
Hey. All right, thank you. Have a blessed evening.
Thank you.